Hi, my name is Clay Josephi. I'm an emergency physician at Barton Memorial Hospital and with the Barton Health System. And the topic of today's talk is alcohol withdrawal syndrome. Specifically, we want to introduce a protocol or a clinical management pathway for the management of moderate and severe alcohol withdrawal syndrome. And we're going to divide this talk into two parts. The first part, we're going to focus on the background, including some of the basic pathophysiology of alcohol withdrawal syndrome, some of the history of alcohol withdrawal and its therapies, and some of the evidence behind some of the rationale for our preferred approach to managing these sort of sicker subset of alcohol withdrawal syndrome patients. In the second part, we will focus specifically on the protocol, and we'll go through some of the nuts and bolts of the protocol and how to identify patients and how to implement the protocol itself, which is a diazepam-based escalating dose protocol for the management of alcohol withdrawal. Okay, so let's jump into part one, the background. So the objectives overall today ultimately will be to introduce the protocol, but first we have to do some housekeeping, really have to talk about some of the background concepts regarding alcohol withdrawal, a little bit of epidemiology, and a little bit of how we identify and manage these patients and some of the rationale for why we do what we do. Secondarily, we're going to talk about the patient selection criteria and sort of enrollment into this pathway and sort of identify who meets criteria for moderate and severe withdrawal and who would benefit from a protocolized approach such as this. And then we're going to talk about some evidence. When I say the evidence, we're not going to do a huge lit review, but I do want to focus primarily on a study or two that really sets the backbone for our protocol so that people can understand some of the origin and some of the background of this approach. And then lastly, in the part two of this lecture series, we'll talk about the protocol at length. So if you want to learn about that specifically, just go right to the second part of the podcast. Okay, so first let's talk about some background. There's many issues I think we need to kind of talk about to get on the same page, and we'll discuss a little bit of background in history and pathophysiology along the way. First of all, in case you haven't noticed, alcohol withdrawal syndrome is very common. It's even more common than we think. Clinically, the numbers are quite staggering on this. The half of adults in the United States over the age of 12 currently report drinking, and 1 in 10 of those patients or those people, humans, report dependence. So 1 in 10 ICU admissions related to complications of alcohol, and it generates about 13% of costs of ICU admissions. 1 in 4 non-fatal MVCs are related to alcohol, and 1 in 6 postoperative patients have been shown to have withdrawal, and 1 in 3 trauma patients admitted to the hospital will potentially have withdrawal, and about 1 in 4 patients with known alcohol use disorder will withdraw while they're in the hospital. And alcohol use disorder is sort of a broad term. There's validated screening tools you can use to kind of identify some of these patients, and it may behoove all of us to kind of ask all of our patients who are being admitted to the hospital some of their use patterns so you can get a feel for that. And the bottom line is that 1 in 5 of all patients admitted to the hospital for any reason are at risk of withdrawing in the hospital. So it's a pretty big deal. So we're going to kind of back up in time, back to the early 80s and 90s when they started to recognize the relevance and the importance and the prevalence of alcohol withdrawal syndrome in the hospital setting. And at that time, they were basically treating people in the hospital for prophylaxis using mostly benzodiazepines. Even at that time, the first trials were done in the 70s and 80s about benzodiazepines versus other agents. And so things like chlorodiazepoxide were actually very popular in the 90s. Initially, they were largely administered in what's called a fixed dose therapy, meaning they were receiving it on a scheduled basis around the clock plus PRN for symptoms. And subsequently, some studies were done that actually started to develop the next concept, which I think it's important to address, and that is that a symptoms-triggered, protocolized approach to alcohol withdrawal is superior to, however you want to call it, usual care or fixed dose therapy. So this goes back in time. In the 90s, there were first randomized controlled double-blind studies that actually compared patients who were getting fixed dose therapy. So they came in and they were at risk for alcohol withdrawal, or they were demonstrating some mild alcohol withdrawal, and they were given therapy around the clock based on a fixed schedule, say QID, chlorodiazepine epoxide, for example, plus some PRN dosing for other clinical metrics. At this time, they actually started to compare this versus a symptoms-triggered therapy approach, and they showed in the first randomized controlled trials that there was a significant reduced use of benzos and a significant shorter length of stay in the hospital with protocolized symptoms-triggered approaches. And this was really the origin of CEWA as we know it, because following these studies, there were a couple done in tandem that were prospective and double-blinded and showing reduced length of stay and reduced benzo exposure and some other sort of secondary outcomes. It really led to this idea that symptoms-triggered approach using a validated scoring system such as CEWA was superior to just treating them either PRN as physician discretion or fixed dose therapy. So after this time, subsequent observational data consistently showed other outcomes, including ICU length of stay, decreased need for mechanical ventilation, decreased ventilatory days, decreased nosocomial infections. And these were largely, again, observational studies, but essentially at the end of the day, the fact is pretty well agreed upon that a symptoms-based approach, symptoms-triggered approach to alcohol withdrawal using a validated scoring system is superior to just treating them either on a fixed dose fashion or PRN. So this was the study in the 90s that I mentioned. I only included here because it's a landmark. This is an RCT. They were actually giving chlorodiazepine epoxide, I think QID, and the fixed dosing, and then they were doing symptoms-based therapy based on a CEWA in the intervention group, and showed a duration of treatment time 68 hours versus 9 hours in the intervention group. So again, this is redundant, but these are the studies that kind of formed the background for how we came to treat alcohol withdrawal in the hospital the way that we do now. And here's the second study. It's often cited. I included so you can see this citation basically. This was again an RCT in 2002, fixed dose versus symptom trigger therapy, shorter duration of therapy, and less benzodiazepine exposure overall. Okay, so this was the birth of the CEWA, and this is how we came to address these patients by going to the bedside and doing an assessment of the patient, and then using that assessment, the objective measure of the assessment, to trigger our therapy. And again, there are many variations of how people approach this. The CEWA became a bit of the standard to do this, and as you can just see from looking at the slide, it's fairly complicated. There are 10 items. It does require a cooperative patient. There's a lot of interaction between the assessor and the patient. There's a lot of questions. How does this light appear to you? Does it hurt your eyes? Are you aware of your surroundings? And are you aware of the sounds? How do the sounds affect you? And then there's some objective kind of observation measures too. But anyway, it does require a cooperative patient, and it's a little bit involved and takes somewhere on the order of a couple of minutes to 5 minutes. Okay, so let's fast forward in time. And the symptoms-triggered treatment of inpatient alcohol withdrawal became fairly standard. And then these authors in 2007, Critical Care Medicine, were somewhat, I guess, the first to report a trend in the administration of therapies, not only on a symptoms-triggered protocolized approach, but also in an aggressive, escalating fashion to treat the existing symptoms until they were gone. So actually titrating to effect, rather than just treating QID plus PRN, symptoms-triggered, this study looked at a protocol in which they would actually stand at the bedside and do assessments of the patient every 15 minutes and continue to escalate dosing. So I include this study here. This was kind of a retrospective before and after study, and it was done at Bellevue Hospital in New York, and it was published in 2007. And this was essentially, they looked at the charts before they instituted a protocol it was a diazepam based protocol with phenobarb adjuvant, and it was based on bedside evaluation of the patient in like a Q15 minute fashion. So it instituted a protocol of escalating diazepam. And following the institution of this protocol, they collected their data, and they did a retrospective analysis of the sort of before and after strategy. And their results were essentially, one of their primary results was they observed, and again, I emphasize that this is an observational study. They observed a reduction in the need for mechanical ventilation in the post-protocol group with a number needed to treat of about 4. So there was about a 25% absolute risk reduction, and it was statistically significant. Now, again, an observational trial and it's retrospective, but this really framed, I guess this was more of a description of people's clinical experience as this protocol and these types of protocols with escalating therapy meeting with a predefined clinical endpoint of a sedation score, as opposed to just treating on a scheduled basis with PRNs, really standing at the bedside and treating until you achieve your target. And a lot of people had been starting this, but this study really was the first to show a clinical, to describe their data on this experience. So this is fairly common practice in intensive care units around the United States and Europe and elsewhere, no doubt. But this is an example of a common pathway. And this is an example of what they did in the study. So they identified patients who were in moderate to severe alcohol withdrawal, and they enrolled them in the protocol. And then they would calculate a symptom score, and they would go to the bedside and they would load them with an agent. In the study, they would load them with diazepam, and then they would recheck them every 15 minutes. And if they continued to meet a certain scoring criteria of agitation, they would continue to treat them in a fashion that included escalating doses. So every 15 minutes they would repeat their dose, and then the next 15 minutes they would double the dose to 20, and then another 15 minutes they would repeat that dose, and then another 15 minutes they would go up to 30, and this is all diazepam. And then ultimately, after a total of 320, in the study I think it was less, after a certain amount of diazepam was administered, they would move on to phenobarb and start to administer phenobarb. So in that study, they showed a number of endpoints, or I guess outcomes, in their retrospective analysis, including decreased nosocomial infections and some hard clinical endpoints. It's difficult to interpret this kind of study in terms of those types of patient-oriented outcomes because of the retrospective nature, but for example, like prior to the institution of this protocol, they were maybe treating the patients very differently, and maybe they were intubating more patients and putting patients on mechanical ventilation and giving people infusions of long-acting benzodiazepines instead of this sort of titration approach. And so that's going to change endpoints such as ICU length of stay and mechanical ventilation needs. So anyway, that's kind of the nature of retrospective studies, but they really showed an improvement in their overall outcomes in their hospital. Okay, so having said that, we, I think, made the point that symptoms-triggered approach is superior, and for the sicker subset of patients, it seems that a symptoms-driven, titrating, escalating dose approach, sort of a loading phase approach to patients who are a little bit sicker is superior. So now we want to talk a little bit about the pathophysiology of alcohol withdrawal. And we're only going to talk about this to the extent that it helps us to understand the targets of our therapy. Okay, so the short story of the CNS and how it interacts with alcohol has to do with GABAergic signaling and glutamatergic signaling. And really you can think about it as the CNS has two sort of chief regulators of inhibitory signaling and excitatory signaling. And the two chief regulators, for the most part, are on the inhibitory side is GABA, or GABAergic signaling, and on the excitatory side is glutamatergic signaling. And when you're in homeostasis or equilibrium in your normal resting state, these two sort of gatekeepers of the CNS reach a homeostatic equilibrium so that they are in balance. So if you drink alcohol, if you go binge and you have like an acute exposure to alcohol and you become intoxicated, the intoxicated state is a state neurochemically in which GABA signaling is influenced by alcohol such that it potentiates GABA inhibition of the CNS, and you get the clinical state of intoxication, which initially is sort of anxiolysis and disinhibition, and then later becomes you can become obtunded, you can have decreased arousal, decreased sensorium, decreased reflexes, decreased vasomotor tone, and myocardial suppression, and loss of gag reflex. And so ultimately it's just a global inhibition of the CNS. When you have chronic exposure to ethanol, the neurochemistry starts to change. Chronic exposure has some changes on the CNS that influence this balance. Essentially, the GABA signaling becomes downregulated. Okay, so the GABA signaling becomes less sensitive to the alcohol and less sensitive inhibitory signaling, and simultaneously glutamatergic signaling is upregulated, so that in this state you have exposure to alcohol, but you have a limited effect of that alcohol on the CNS. So this is called tolerance, and this is how people walk around with a blood alcohol level of 300 and can still talk to you and ventilate. So that's what happens, the downregulation of GABA in chronic exposure and the upregulation of glutamate. So if you have an acute cessation and you take that ethanol away from the system, now you have some important changes that have occurred, chronic changes from chronic exposure, and now your GABA is downregulated and your glutamate is upregulated. You take the alcohol away and the GABA is unable to compensate for this unchecked sort of glutamatergic excitatory signaling, and that results in the clinical state of withdrawal. Okay, so there's a little bit more to the story, and I think it's worth noting that NMDA signaling is also known to participate in this milieu, including with alcohol withdrawal. Similar to the glutamatergic side of the CNS, it becomes upregulated to the point that with acute cessation you have increased NMDA signaling, and there is currently investigation into the utility of potentially ketamine, which is an NMDA receptor antagonist, in the therapy for acute alcohol withdrawal syndrome because of this underlying physiologic mechanism with NMDA. But we're going to focus on GABA primarily, and a little bit to some extent glutamate. So ultimately you have a decreased GABA signaling and an inability to compensate for overwhelming glutamatergic signaling. So your therapy then is going to target GABA, potentiate GABA, and bring this balance back into equilibrium. So this is the GABA receptor, and the GABA receptor is the chief inhibitory player in the central nervous system. You can see that there is a barbiturate site on the GABA receptor. There's a benzodiazepine site. Both of these bind. They are activators of this receptor. This is a transmembrane receptor. And there's a GABA site, and the receptor itself is actually a transmembrane chloride channel. So alcohol withdrawal syndrome is a decrease of GABA signaling by dysregulation of this underlying physiologic mechanism. And so therefore, and this is, as we just said, therapy is going to be targeting this receptor, this GABA receptor, activating it, and thereby increasing inhibitory signaling, which is dysregulated in the CNS. Okay, so the next point of housekeeping and background is that benzodiazepines are, generally speaking, the first-line agent in alcohol withdrawal therapy. This is that's a little bit of an umbrella term, and I don't want to sound too specific there, because there is a bit of a controversy, and there is definitely some potential targets for adjuvant therapies that people are using in clinical practice today. But in general, overwhelmingly, people agree, and the literature supports the fact that benzodiazepines are the first line agent. Okay, and this goes back to, I believe, the 1970s. They did a randomized double-blinded control trial of chlordiazepoxide versus other agents, including a first-generation antipsychotic and also hydroxyzine as an antihistamine. And essentially, they showed that benzodiazepines were superior. And that formed the sort of general consensus that benzodiazepines were the first-line agent for alcohol withdrawal syndrome. And there, interestingly, subsequently, there is not a lot of great prospective data on benzos versus other agents. There certainly is a lot, and there's a lot of varying methodologies. That's why I include this study here. This is the efficacy and safety of pharmacological interventions for the treatment of alcohol withdrawal syndrome in the Cochrane database. And this is a systematic review published in 2011. And it's quite robust. I mean, there's a lot of studies. There's 5 reviews, 114 studies. It's basically where you want to go to do your deep dive and to do your lit review and look at the bibliography, because most of these studies that compare benzos to other agents and look at some of the outcomes in observational studies are cited in this study. So the conclusion of the authors in this systematic review is that benzodiazepines are superior for seizure prophylaxis and likely superior to antipsychotics on a number of outcomes. So, I'm just saying this as a background for the generally accepted concept that benzodiazepines are first-line treatment. So that leads us to the next question, which is a really great question and very interesting. Is one benzodiazepine superior to the others? So first off, I just want to say that we're going to focus on patients who are admitted to the hospital. We're not talking about outpatient management of symptoms of alcohol withdrawal. And we're actually not talking very much today about patients who have mild alcohol withdrawal who are in the hospital. We're talking about patients who need, IV therapy and who are in the moderate to severe symptoms classification. And the real question comes up, lorazepam versus Valium or diazepam. And there's basically these two camps and some people are very adamant about lorazepam being superior for a number of reasons, and there's another camp that is really in favor of diazepam. The one thing that I hear the most is that the tox guys really like Valium, and I've heard that both in just passing and discussion, but I've also heard that, and that is actually sort of the message that's being generated in the literature, with the predominance of these studies being diazepam-based protocols. So this really comes down to two things, and that is pharmacokinetics. So there are some favorable characteristics pharmacokinetically of both of these drugs that people seem to like, and the second thing is clinical experience. And I think that overall, I think that more people are really turning to diazepam for this indication, and the reasons for that are really pharmacokinetic considerations. So the first thing is that diazepam has a very fast onset, and when you're talking about an approach to a patient such as a severe alcohol withdrawal patient, that you want to go to the bedside and rapidly escalate their doses and rapidly titrate them to a targeted clinical sedation score, you really want a drug that works quickly. And diazepam has an onset of 2 to 3 minutes, and whereas lorazepam, the onset is a little bit slower, 5, 10, 15 minutes or so, and it's fast, but it's not quite as fast. And then the second thing about diazepam is that the peak clinical effect is in the 5 to 30 minute range, probably more like 15 minutes, whereas the peak clinical effect of lorazepam is definitely delayed from that. So in that regard, diazepam definitely has an edge on lorazepam in terms of the strategy where you want to evaluate the patient every 10 minutes to continue your dosing strategy and not get into this stacked dosing phenomenon that you can with lorazepam. The second thing that people often state about diazepam is that the metabolites of diazepam are somewhat favorable because they are sequentially broke down by the liver in a number of steps and resulting in these active metabolites which have very long half-lives. The breakdown products of diazepam are things like temazepam, which is also another oral agent, and oxazepam, I believe, another oral agent that's used internationally a little bit more. But anyway, these are long-acting benzodiazepine metabolites or diazepam metabolites that continue to have physiologic activity for up to 100 hours in certain patients. And this is particularly true of people who are obese and who have a large volume of distribution physiologically. So the proponents of this metabolite aspect of diazepam say that that's a good thing because it's sort of this sequential excretion, and they, this the self-tapering, some people refer to it, and they feel like that it's kind of a more smooth taper. Now, I'm not aware of any studies that actually substantiate that, but that's definitely something that people talk about. And then also there's been a couple of positive studies looking at diazepam-based protocols who have demonstrated or suggest really positive impact on clinical care. So diazepam is really gaining steam, so to speak. Now, again, there's no head-to-head randomized control trials. The lorazepam camp, on the other hand, is, and the other thing is this propylene glycol content in these two different medications. Propylene glycol is a diluent and is associated with metabolic acidosis and some other metabolic perturbations in critically ill patients. And you can certainly get propylene glycol toxicity with large doses of benzodiazepines, and lorazepam or diazepam has much less propylene glycol in it overall. So that's the diazepam camp. The lorazepam camp, of course, is the shorter half-life. It's not in the system as long, and basically, the other thing about lorazepam that a lot of people like is that it doesn't require an intact hepatic function. Like patients with alcohol withdrawal syndrome are much more likely to have clinical and subclinical hepatic dysfunction, and the lorazepam can be metabolized even by the cirrhotic liver. Okay, so there you go. That's the lorazepam diazepam background, and I know that you will hear both sides of that from different clinicians, and it's largely based on opinion, as there is no real good randomized prospective head-to-head evidence on these. The one thing I do want to point out is that if you're, as we talk about a diazepam-based culture, diazepam-based protocol for the management of these patients, it is important to understand that loading someone up with parenteral diazepam is probably not the best idea for the undifferentiated ER patient who is probably going to go home owing to the long half-life. There are some theories that theoretic risk that they may go home and have ethanol exposure and have a synergistic respiratory depression with the long-acting benzo. But, of course, that's just a theory. Okay, so the next agent that we want to talk about, having said that benzodiazepines are the first-line agent, we are going to, step out of the box and look at some of the other underlying chemistry and pharmacology so we can understand the other treatment options. So phenobarbital is a very popular agent. The thing is about phenobarbital, it's been used for decades, and one of the things that I find interesting about phenobarbital is that we really don't use it. It's actually has a great track record. There's a substantial amount of evidence behind it, and it really has a really favorable pharmacological profile. So let's just talk about it briefly because it is going to play into our protocol, and it's important to really understand the background and the mechanisms of phenobarbital. So phenobarb, just like benzodiazepines, and just like propofol to some extent, operate at the GABA receptor, and they are agonists, and they increase chloride influx into the cell and hyperpolarize the cell and disable the cell from signaling, thereby inhibiting the CNS. So this is very much like benzodiazepine use, and you can see at the receptor site there's actually a binding site for a barbiturate and a binding site for benzo. So it enhances CNS inhibition by action at the GABA receptor, just like the benzodiazepine. The other thing about phenobarb that some people talk about is that it actually suppresses glutamatergic excitatory signaling, and this is much less understood to my knowledge, but it actually suppresses excitatory signaling as a secondary mechanism. So in some ways, and certainly people who are phenobarb believers state that it's ideal agent for alcohol withdrawal because it's addressing both sides of the dysregulation instead of just the GABA side. So it has been successfully used both in combination with benzodiazepine and also in monotherapy for severe alcohol withdrawal syndrome. We'll talk a little bit about that. But in most modern practices that I'm aware of, including what we plan to do here at our facility, it's going to be used and encouraged to be used as an adjuvant to a benzodiazepine escalating dose approach, like we discussed earlier in the previous study. So I do want to say one more thing about phenobarb, or a couple things, but for the emergency physician listeners and those that work in the ED, and RNs, et cetera, who are seeing these patients up front when they are undifferentiated and you're still working them up and trying to figure out if alcohol withdrawal is their primary medical problem. This is a prospective randomized controlled trial that's done in the emergency department. And it was interesting to me because the inclusion criteria for the patient population were basically just the provider judgment. The attending physician said, okay, this patient is having withdrawal and we are going to enroll them in our institutional benzodiazepine-based alcohol withdrawal protocol, because this particular facility had a protocol for the management of alcohol withdrawal, which was a lorazepam-based symptoms-driven protocol. So as soon as they met criteria for entry into the institution's benzo protocol, they were enrolled into the study and they were randomized into two groups. And the first group got 10 milligrams per kilogram of IV phenobarbital over 30 minutes as their initial bolus. This is the intervention group. And then subsequently went directly into the lorazepam-based benzodiazepine protocol that pre-existed this intervention. And then the control group received just the institutional protocol, which was lorazepam-based. And the outcome measure, the primary outcome measure anyway in this prospective study, is the admission level, like floor versus ICU. And they found an absolute risk reduction of ICU admission in the intervention group of 17%. And that translates into about a number needed to treat of 6. So for 6 alcohol withdrawal syndrome patients who you decide to treat with the protocol in the ER, if you start with a bolus of phenobarb, you prevent 1 ICU admission. So in my mind, this is a pretty positive study for the early use of phenobarb. But I only include this just to give you some background of how phenobarb is used in this particular disease process. So the last thing I want to say about phenobarb is it's actually been used and to some extent studied in monotherapy for acute, moderate, and severe alcohol withdrawal. So as we stated previously when we were talking about the pharmacology of phenobarb, it stimulates GABA signaling and definitely is a inhibitory signaling via the GABA mechanism, but it also suppresses glutamatergic signaling. And there are some theories that it may actually have some effect on the NMDA signaling as well, as a antagonist. So it's kind of referred to as the hammer of neurotherapeutics, in that phenobarb will really knock anything down. Any sort of agitation or excitatory state, it will knock it down. And that's the fear, right? Like that's probably why we don't use phenobarb very much in our practices, because they've been largely replaced by these, shorter acting benzos, and for whatever reason, phenobarb has fallen out of favor. And one of the reasons, I believe, is because this real fear of it being just too strong. It's going to shut down everything. And you're going to result in mechanical ventilation, hypotension, and bradycardia, and cardiovascular instability. But the literature certainly does not support that, and there's a lot of evidence for phenobarbital use in alcohol withdrawal syndrome, and there's a lot of dosing guidance out there. So I just say that just because I want everybody to realize that phenobarb is a well-studied and a very safe and effective agent when used appropriately. So there is a camp of people who believe that phenobarb is the ideal agent based on some of the things that we've talked about for the management of this therapy, and they advocate for just using phenobarbital as a monotherapy and obviating the benzodiazepines in entirety. So there's a couple of things that this phenobarb camp really says a lot. Number one is there is a known strong association between benzodiazepines and ICU delirium and psychosis. ICU delirium and psychosis is a very big deal, and it's directly linked to mortality in all comers, and it is very common, and it is strongly associated to benzodiazepine use. Even to the extent that the guidelines for management of patients in the ICU and sedation in the ICU is largely moving away from benzodiazepines in a number of avenues, including mechanical sedation for the purpose of mechanical ventilation is really moving towards opioid-based protocols, including what do they call, analgesia-based sedation protocols, where you really optimize the administration of opioids prior to administering sort of PRN intermittent boluses of sedation, if at all. And there's been some prospective trials comparing analgesia-based protocols to standard care, which is infusions or intermittent bolus strategies based on sedatives like benzodiazepines, and there is decreased ventilator days and decreased ICU days that are starting to be shown in the literature. So in general, the association of benzos and delirium is really putting the spotlight on benzos, and they are really being steered away from, in general, almost for just about everything. So the delirium aspect and the association with benzos is a real big problem for this particular strategy. And the phenobarb camp says, well, just avoid the benzos entirely, because they swear by the fact that phenobarb causes less delirium. But, I don't know of any studies on that. The other thing that the phenobarb camp talks about is the so-called paradoxical reaction, and this is the patient to whom you give a little bit of a benzo and they start bouncing off the walls, and it's very confusing clinically. It's a conundrum because you think that they're getting worse from their alcohol withdrawal or their underlying excitatory state, and you give them more benzos, and next thing you know, you're kind of chasing your tail. And paradoxical reactions have been well described, and they have been observed in up to 5% of ICU patients in certain series. So they're very common, and maybe more common than we even think. And the phenobarb camp says, well, paradoxical reactions don't really happen with phenobarb. Whether or not that's true, I don't know, but that's what I've heard. And the other thing about phenobarb, it has a long track record and a lot of history, and we know a lot about its pharmacokinetics, and its metabolism is actually probably more predictable than benzos in general. And some people argue that that's a reason to favor phenobarb. And so here on the slide, you actually see an example of a pathway that you might use if you just wanted to use phenobarb alone. And this is basically the IV phenobarb load, which is a 10 milligram per kilogram over 30 minutes. Again, I know that sounds like a big dose. That was what was seen in that previous trial, but that is the published and recommended dose for phenobarb loading. And this should be done in a patient that does not have other benzos or sedating medications on board, because it'll be less predictable. And then you wait a 30-minute interval, reassess your patient, calculate a score, which we'll talk about later, and then you titrate 130 milligrams on your next dose, and then you go up to 260 milligrams on your next dose 30 minutes later, and you just keep going. So this is just another example, and so that you're aware that this is out there. Okay, the next thing that I want to talk about is neuroleptics for alcohol withdrawal syndrome. And I kind of want to do away with this in some respects, because it's actually a really, really interesting conversation. But in some regards, the use of neuroleptics such as Haldol and carbamazepine and olanzapine, and in our facility to some extent Geodon, has become a little bit popular for treating symptoms that are associated with alcohol withdrawal. And when I say popular, I don't know if that's fair, widespread, but certainly maybe popular in even nationally. It's somewhat of a trend in treating alcohol withdrawals to either use neuroleptics for symptoms management or in combination with benzos for guided therapy for like psychosis or delirium, for example. So it's definitely out there, and it's being done a lot clinically. It actually, Haldol and other neuroleptic agents are commonly on institutional CWIP protocols for symptoms. So I guess it's worth kind of addressing sort of the background of this. In general, they do not address the underlying pathophysiology of alcohol withdrawal syndrome. They don't enhance GABA signaling the way that benzodiazepines do, and they should not be used as a replacement for benzodiazepines, and they should be considered only as an adjuvant to an underlying benzodiazepine-based protocol. So having said that, I think that it's worth noting that this is a very interesting area of research, and there is data that neuroleptics can improve symptoms of alcohol withdrawal, and they have been compared. For example, carbamazepine has been compared in randomized data to benzodiazepines and shows a mild improvement in CWIS scores when compared directly to benzodiazepine in mild withdrawal. And then there's a lot of studies out there looking at carbamazepine and also olanzapine in the outpatient management of alcohol withdrawal symptoms, and they have been shown to improve symptom scores and also things that are important, probably like craving and symptoms, but they have not been shown to be better than placebo for hard endpoints such as days free drinking or relapse rates. In addition, if you look at the systematic reviews, there are a number of dropouts in the trials in the outpatient setting for alcohol withdrawal symptoms management for side effects and stuff. So it kind of makes the data a little bit less robust. But in general, there really has been no improvement over placebo for endpoints that are clinically relevant. But there is probably a role for symptoms management in the outpatient treatment arena, although that role is not entirely clear. All right. But in general, for patients admitted to the hospital who are receiving parenteral therapy for alcohol withdrawal syndrome, there really is the role of neuroleptics is limited and should be probably specific clinical goals that the physician is trying to achieve, such as the addressing psychosis, delirium, or trying to get a clinical effect in addition to the benzodiazepine approach. Okay, so that's that for neuroleptics. The next thing that I wanted to address, and this is just briefly, because this is a whole other talk for another day, and that is about adjuvants. And neuroleptics are definitely one of them. Adjuvants being therapy that can be used in combination with benzodiazepines for alcohol withdrawal syndrome. And I just want to emphasize that because all of this stuff should be used in combination with benzodiazepines. So the most commonly used adjuvants in alcohol withdrawal syndrome, and I just want to say these are the benzo-resistant patients. You really get into this position every now and again where you're really escalating your benzodiazepine therapy and there really is no response, and maybe you're treating the tachycardia and the hypertension, but the patient is still very delirious, and they're having tactile and visual hallucinations, and they're crawling out of the bed, and you're looking for something else because your patient is resistant to what you're feeling is aggressive therapy. That is the time to turn to adjuvants. So the adjuvants that are most commonly used include things that you would expect just based on a neurochemical, the underlying pathophysiology that we just discussed. I mean, you're in this excitatory state, which results in a sympathomimetic state peripherally, and you end up having hypertension, tachycardia, and you are generally sympathetic in your tone. So beta blockers have been used in alcohol withdrawal syndrome, particularly in patients in whom you have a critically ill patient who also has underlying coronary disease, and you don't want their heart rate going 160 and their blood pressure to be 230. and you're giving them a lot of benzos, giving that patient a beta blocker is certainly a reasonable intervention. However, I will say that propranolol has been associated with ICU delirium in observational studies. So I think using esmolol or something like that is probably a better bet. Although, again, there's no data to guide that. The second category of medications that are commonly used are alpha agonists. And again, this is a very logical approach to the underlying neurochemistry of this. The two most commonly used agents are clonidine and dexmedetomidine. And clonidine has been used for years for this indication, essentially alpha agonist in the central nervous system. So these alpha receptors in the central nervous system, again, as a reminder, are mediators of sympathetic outflow from the nervous system, from the central nervous system. So if you agonize these alpha receptors, it's this inhibitory feedback, and it decreases global CNS sympathetic output. So you're looking at decreased blood pressure, decreased heart rate, decreased sensorium, decreased agitation, and you get a patient who, and that's why clonidine has been used for so long, is to treat things like hypertension in association with alcohol withdrawal. And then now there's been some observational studies on this dexmedetomidine, or dexmedetomidate, also Precedex, as an infusion. And again, this is a very powerful alpha agonist, and it actually results in basically a dissociated patient with a significant improvement in vital signs. So the underlying question here, when you're using things like beta blockers and alpha agonists, particularly something like Precedex that's really going to knock your patient out, the underlying question that has not been addressed in the literature is, are you masking the underlying pathophysiology of alcohol withdrawal syndrome? Like, are you going to prevent endpoints such as seizures and coma and other multi-organ dysfunction from this specific, alcohol withdrawal physiology? These medicines seems to be effective in managing symptoms in the resistant cases, but we don't know yet if the outcomes are the same, because those RCTs and that kind of trial looking at clinically oriented outcomes hasn't been done. So using these things at this time in history should be used in combination with benzodiazepines, and recognizing that their impact on the global outcome from the underlying alcohol withdrawal syndrome is uncertain. Okay, so, and that goes for neuroleptics as well. Again, you can definitely use things like Haldol, and I guess carbamazepine and valproic acid have been the most studied. So I don't really see much in the literature for Geodon or even for Haldol for that matter. But like giving these medications on top of a benzodiazepine can really help to sedate a patient who is really in that upper level of agitation stage. +3, +4 on a Richmond, they're danger to themselves, they're pulling their lines. Giving them these neuroleptics can really help as an adjuvant, but you need to recognize that it's not treating the underlying pathophysiology. So you need to continue with benzos. Now, ketamine is an interesting conversation because ketamine has been used for just about everything under the sun. And the NMDA signal disruption in chronic alcohol exposure is fairly well understood. And so it seems to be a very logical target for alcohol withdrawal syndrome to give ketamine in terms of its NMDA antagonist effect, because the upregulation of NMDA signaling is known to be associated with alcohol withdrawal states, and the dysregulation of NMDA signaling is known to be associated with chronic ethanol exposure. So giving an antagonist in this excitatory state seems very logical. So I think that and there hasn't been any large studies on this, but I think that it's reasonable at this time, based on the evidence that is available, to give a patient ketamine for this indication if you are up against a wall and you're in this benzo resistance phase. And then the next agent that's commonly used is propofol. Propofol activates the GABA receptor and is theorized and is thought to have some NMDA antagonistic effects as well. And also is a very good agent for this. So ultimately, if you need to put a patient on a mechanical ventilator, propofol is probably a really good choice for this. Now, the downside to propofol is hypertriglyceridemia and the so-called propofol infusion syndrome, which is rare. Okay, Now, the last thing we want to talk about in terms of background, I know that we've really covered a lot of ground in this segment, and I think it's important to kind of get a feel for where we're at so we know where we're going. And the last thing I want to talk about is the metabolism of ethanol and how it applies to critical illness. And the reason why I want to talk about this is because your patients who come in with alcohol complications and who are at risk of withdrawal or present in withdrawal are also going to manifest multiple other first symptoms. They're going to come in with chest pain, shortness of breath, gastritis, pancreatitis. They're more likely to have occult trauma. They're more likely to develop sepsis, and they are a fairly high-risk population, but they're going to have multiple complaints that you're sifting through when they come in. And so these patients have predictable metabolic and laboratory perturbations, and knowing the underlying physiology for those and some of the biochemical pathways, I think, is very helpful in sort of sifting through what can be a very confusing clinical evaluation of some of these patients. So first step, you add ethanol into the system. Ethanol exposure and ethanol metabolism is the first step in the ethanol metabolism is performed by an enzyme called alcohol dehydrogenase. Alcohol dehydrogenase converts ethanol into aldehyde or acetaldehyde, and one of the byproducts of this is this NADH. All right, and then acetaldehyde is subsequently converted to acetone, and more NADH is produced, and more NAD is used up. Okay, and so you end up with this sort of NADH accumulation, and this is kind of an important step because this results in multiple things. So you end up with this NADH accumulation, and concomitant NAD depletion, which leads to a number of things, one of which is gluconeogenesis is actually shut down because gluconeogenesis depends on NAD availability. So regardless of other nutritional factors and whatnot, you have a shutdown of gluconeogenesis, which leads to a low insulin state, which leads to, just like in other diabetic ketoacidosis or diabetic emergencies, you ultimately end up in a lipolysis sort of balance where you're actually breaking down fatty acids for the generation of ATP, and this results in ketosis. So these patients will often have ketosis. The other thing that happens from this NADH accumulation is this reaction of pyruvate metabolism is shunted to the left towards the production of lactate dehydrogenase. Via lactate dehydrogenase towards the production of lactic acid. So these guys are going to be preferentially producing lactate. And that can be a real clinical conundrum because these patients are also likely to have things like pancreatitis and SIRS, and they are also more likely to have sepsis and hypovolemia and other causes that can progress to shock and critical illness of lactic acidosis. So it's a real problem trying to sift through working up a lactic acidosis in a alcoholic, and this is one of the things that's worthwhile remembering. So the next thing is thiamine deficiency. And so thiamine is a cofactor which is required for many aspects of glucose metabolism. And in this case, it's a cofactor for pyruvate dehydrogenase, which also requires NAD availability to convert pyruvate to acetyl-CoA, which is then transferred into the citric acid cycle and onto oxidative phosphorylation. So in the absence of thiamine and in the absence of NAD, this further shunts the reaction towards the production of lactate. Similarly, these patients have a hypoglycemic state for a number of reasons: poor nutrition, and also you have intrinsic shutdown of inhibition of gluconeogenesis rather. And these two factors further shunt pyruvate down the pathway towards the production of lactate. So the whole point in this discussion is that these patients who have chronic ethanol exposure are going to present with ketosis. They're going to present with thiamine and deficiency and hypoglycemia very commonly, and they are going to present with lactic acidosis. And this is part of the reason why. So it's worthwhile addressing these, understanding how this is happening. And so these are some of the first things that you want to treat when you see these patients. And basically what you do is you avoid alcohol exposure. You give them glucose. IV or oral, and you give them IV or oral thymine. And what that does is it reverses some of these processes, and it favors the production of acetyl-CoA from pyruvate instead of lactates, which goes on to oxidative phosphorylation, which is much more efficient way to generate ATP via the citric acid cycle than is the production of lactate. Okay. So that's the end of part one. And I know that that's a lot of information, and you can take it in parts, and I appreciate you listening. And please tune in for the next segment, which will be part two, and we will discuss the protocol for the Barton Health System.